You're very tricky, you know. This move up.
Assalamu alaikum. Good morning. I want to welcome you and thank you for attending our third and last day in the Libyan Cardiac Society conference, the 11th one. This morning we're going to talk about prosthetic valve diseases and assessment of prosthetic valves, and this is what we decided to cover this year. A little change from the previous years where we were talking more about the native valves. Our first speaker is Dr. Ayman Smear. Dr. Ayman is a consultant cardiologist. He's a member of the Libyan Cardiac Society. I want to say that he's been very active and he made a big change and a lot of dedication and positive energy since the first day he came with us. He's also the program director for the Cardiology Fellowship program at Cleveland Clinic, Abu Dhabi. Dr. Ayman is American board certified in cardiology, echocardiography, and nuclear cardiology. Dr. Ayman, the floor is yours.
Thank you, Dr. Hanan, for this kind introduction, and welcome everyone to the final day of the Cardiology 11. I have the pleasure to talk to you today about, can you put the screen please? To talk to you about echo assessment of prosthetic valve. We're going to go to the basic fundamentals. We see this patient a lot, so it's very important to do an accurate assessment to decide what's the next step of caring with those patients, whether if there's acute changes or routine assessment. So hopefully in the next 15 minutes, we're going to go over and identify the normal echo finding for prosthetic valve. You need to know the normal, so you can't tell the difference between the normal and abnormal. We need to recognize the feature of prosthetic valve dysfunction and how to differentiate between normal and abnormal prosthetic valve function and morphology. I also would like to recommend that you review the recent echo assessment prosthetic valve. This is with collaboration. It was multi-society with the CT and MRI, published last year in 2024, and it's free, available for everyone on the American Society of Cardiology website. Highly recommend reviewing this comprehensive paper, which is basically an update of the 1990 document and adding more prosthetic valve. So in the past, we used to, going too fast. In the past, we used to classify prosthetic valve into mechanical and a tissue valve, but now with the advanced technology, we more go surgical valve and percutaneous valve with the introduction of TAVI, talk about balloon expanding and self-expanding. And when we look on the left side of the screen with the surgical valve, we have the mechanical valve on the top. On the far left, we have the bileaflet St. Jude valve. This is the main horse of mechanical valve. The surgeon like it. Cardiologists like it, has good hemodynamic functionality. Then we have the tilt taping test, the York-Shorkey valve. This is taken out of the market in the 19 was first introduced back in 1960 and was taken out in 1986 because the struts that's in the middle that support the disc broke, so create an issue, was got recalled. And we have the Volkswagen valve, the Cajun ball, which is the first valve was created back in 1960 in Oregon, United States. Surprisingly, I just saw a case a few weeks ago. I read the echo and it was interesting to see that kind of echo valve anymore. At the bottom, we have the tissue valve. They could be both bovine or bovine, porcine, or even pericardial. And the main one we use, the surgeon used the stented. They have better stability, but some people, especially when they have a small aortic root or air valve area, we use the stentless valve. And we have also like combined with the valve in addition to the ascending aorta. So these are the type of the valve that we see. There's important basic principle with all prosthetic valve that you need to know that all the prosthetic valve, either tissue or mechanical, they're mildly stenotic. So if you think about it, we're taking a severe disease and you're putting another mild disease shouldn't give you a symptom. So those patients are not cured with valve disease. The other thing, all mechanical valve, they have what we call built-in washout jet, mild regurgitation, and this is the dynamic, and it's a good one to prevent valve thrombosis. All prosthetic valve, they fail the test of time, and they are prone to dysfunction, some of them more than the other, and we'll talk about that as we go. So these are the type of the valve that you're going to see, mechanical valve. I said on the top, the bileaflet, that's what you're going to see majority of your time, if not all the time. And if you can see, you'll have a 3 washout jet. These are homogeneous jet. They're 3. They're each one of them going to the orifice, whether the central small orifice or the lateral large orifice. They're usually, like I said, homogeneous. They prevent thrombus and low velocity. Then we have the tilt taping test, which is one flame of fire. And then the cage ball, we call the 5-4. So these are the valve that you see with the physiologic, these are normal findings. So seeing this doesn't. Now there's a difficulty assessing prosthetic valve because they have the acoustic shadowing and flow and mechanical reverberation. So they do intervene. You see that more often with the mitral valve because it's too posterior structure when you do transthoracic. And with the aortic valve, with transthoracic, usually it's better to do with transthoracic because it's anterior compared to the TE, transvagal, with the aortic valve. So it depends on your modality, you have advantage. So transthoracic for aortic valve is a decent assessment. But for mechanical, TE would be better option because you go from the left atrium very close to mechanical valve, and it depends, and show you some example. Some say like why that's important, because acoustic shadowing reverberation artifact can mask significant valve lesion. And this view here, you're going to see 2 artifacts with the mechanical valve. The red one, these are the acoustic shadowing. These are the black area that you won't see anything behind. You won't see physical structure. You won't see regurgitant jet or any color. The yellow arrow, this is the acoustic shadowing, and the red arrow, these are reverberation artifact. If you look at the spectra, the Doppler, you can see the click, the closure line, very sharp line in the middle with the white arrow, and you can see that also with the ammo, the opening and the closure of the prosthetic valve. And like I said, this is a problem. Those artifacts are a problem. For example, looking at this apical view of transthoracic echo, you can see there's a mechanical mitral valve at the mitral position, and you can see the reverberation artifact and the acoustic shadow of the ring. Now, looking at the thoracic echo with most expert eyes, I think you would agree with me, you see some mitral regurgitation on the left corner at the left atrium there. Now, doing a TE for this patient, you can see with the green arrow, significant gap, and there's severe paravalvular leak that can be easily missed even with the expert eye. So the message from here, I would say have a very low threshold to do a TE when you have patient prosthetic valve that you suspect they have valve dysfunction, because paravalvular leak is the Achilles head of transthoracic echo in patient with prosthetic valve. Now, there's some normal vibing that you need to be aware of, so you don't panic. We call them the microbubble or cavitation problem, and those usually happen more often with the mechanical mitral valve due to rapid change in the pressure with the ultrasound, so you see those kind of very vigorous ones. So this is a normal finding. Don't panic, they're not thrombus, or not vegetation, normal finding. Another thing also we see with the mechanical prosthetic valve, strand or filaments. These are small microfilament, usually at the suture line. So they're not, you see them more with the mitral valve, and these are not thrombus, are not vegetation, but they could be a nidus for a thrombus. So just be careful with that and interpret that on the clinical setting. But if the patient doesn't have any feature, such as endocarditis, don't think this is endocarditis. You can see that on the right screen, those microfilament. It's like lamellar excrescence of the aortic valve. It's a wear and tear damage. Now, there's very important, I want your attention here. There's very important concept you need to understand. The valve size is not the effective orifice area. The valve size, that's when the valve comes from the shell, it's the external diameter. The effective orifice area, it's more physiologic. For example, on the far right, when you have like the bioprosthetic valve, the effective orifice area is circular rounded, and this is how the flow conversion go from the internal diameter into the other chamber. Patient with bileaflet mechanical valve, for example, you have a 3 orifice area, small one in the center, and the large one, too large on the side. So this is important concept. So the question, how we calculate effective orifice area if it's not the valve size? We use 2 methods. We use the continuity equation, looking at the LVOT VTI with the cross-sectional area of the LVOT over the mitral valve VTI. That's give it as a way to do that. And here, or you look at the manufacturer. Each manufacturer, they'll give you their valve size and estimated effective orifice area. So that's something. And here I would like to caution you about not to use the pressure half time to calculate the valve area in prosthetic valve, whether tissue or mechanical. we don't use pressure half time to calculate the valve area in prosthetic valve. We do that for native valve, but we don't do it mechanical valve. There's still good use of pressure half time, and we'll go over it in the next few slides, but this is something I want you to be aware of, and so you don't make that mistake. Now, when you assess the patient with the prosthetic valve, very essential to integrate the clinical data. The patient blood pressure, the heart rate, the body surface, very important, because, for example, when the blood pressure is low, you're going to underestimate the velocity across the valve. When the heart rate is fast, you're going to overestimate that. So it's very important to put them on your echo report. And I asked the 3W, we called what type of valve is this? And what's the size? Because this size and type of valve will give you the normal gradient and velocity across the valve. And then you need to know what the surgery was done. For example, if you have a patient that has just surgery a month ago and have a problem with the valve, increased velocity, you think about thrombus more than PANAS. PANAS takes years, but if this valve has been there for 2-3 years or 4-5 years and the velocity is going up, now you think about thrombus here and PANAS. And it depends, so the timing is very important to help you differentiate what's causing the problem with the valve. And the other two, you need to, if you see elevated velocity, you ask yourself why these velocities are elevated. Looking at the two echoes is very important, even though there's those reverberation artifact acoustic. It tells you the position, the stability of the leaflet, and you look at the chamber size as well, give you as a clue if there's something wrong with the valve. For example, if there's significant paravalvular leak for the mitral valve, you expect the left atrium to be enlarged. Here's an example. If you can see this apical view, three-chamber view, you can see there's aortic prosthesis, and this big kind of rocking motion. It's very unstable. There's valve dehiscence here. So the 2D help you. There's something wrong with the valve. 3D has added a lot to us. It kind of make us look, see what the surgeon sees in the OR with the mitral valve prosthetic, the invasive view of the mitral valve. The first example here by leaflet mechanical valve. Then we have a tissue valve. And main advantage of 3D echo here, the color 3D, that help us identify paravalvular leak. We can see here there's a 3 jets outside the ring. So this, you're not going to see that with transthoracic. But so interestingly, the main disadvantage of transthoracic echo, it's the main advantage of 3D, especially with the color. Now look at Doppler. Actually, this is what we use to give us clues what's wrong with the valve. Looking at the color velocity. Important thing you need to know, because what affect the velocity and gradient, the valve size. If it's small, you'll have higher gradient than large. The valve type as well. Usually mechanical valve, they have better hemodynamic than prosthetic valve, so usually have better velocity, and the flow rate that depend on the blood pressure and heart rate. So that's why we said very important to get those vitals when you start. When you have elevated, so you got your clue from the transthoracic, from the Doppler technique. Now we see why the velocity problem. Is it obstruction? Is it regurgitation? Or could be this prosthesis patient mismatch or high cardiac output state like anemia, post-op, or tachycardia. So let's take an example of the aortic valve and things I would like you to pay attention. There's certain criteria we look at, but mainly look at the jet contour. If it's triangular, early peaking, that's normal. If it's parabolic, late peaking, that's abnormal. And we measure something called acceleration time, which is from the onset of the opening of the valve to the peak. If it's less than 80, the valve is normal. If it's more than 100, something is abnormal with the valve. Between 80 and 100, that's the gray zone. So these are things. Another thing I would like to look at, what we call the DVI, the Doppler Velocity Index. If less than 2.5, that's abnormal. Basically, you look at the velocity at the LVT divided by velocity across the aortic valve with the CW. If less than 2.5, that means the flow accelerated 4 times the normal. There's something wrong with that valve. That paper I mentioned earlier in 2024, they have a very nice algorithm. You start with the peak velocity, of course, aortic valve. It's more than 3, you got your attention. Remember, I said all prosthetic valve are by default, they're mild stenosis. So the 3, for example, aortic valve, this is the range of moderate. So if you see that range 3, remember the number you need to remember with aortic valve, peak, the velocity, if more than 3, something wrong. Then you look at the acceleration time. More than 100, something's wrong. Then you use the DVI. If less than 2.5, you know there's something wrong with the valve. Now let's switch gear to the mitral valve. And here we said the first thing you look at with the aortic is the peak velocity. Here look at the mean gradient. If it's more than 5, this is something wrong with the valve. So the next step you do, you look at the E velocity. If it's more than 2, there's something wrong with the valve. Remember, aortic valve, we said
2 minutes.
3. Thank you. So we said the aortic valve more than 3, mitral more than 2, if that's the high. you divide the VTI of the prosthetic valve over the LVOT VTI. If it's more than 2.2, this is something wrong with the valve, and this is an example. If you can see it, I'm not going to go over the number, but this patient ended up with the prosthesis VTI over the LVOT of 2.6. Now, if you add the TR jet more than 3.4, this year increased sensitivity is made to 100%. So using just that E velocity of VTI ratio more than 2.2, that gives you sensitivity of 90% and specificity of 92%. If you add the TR more than 4, you almost get 100%, so very helpful. Now, earlier we said we don't use the pressure half time for valve area, but the pressure half very helpful when you have high velocity to tell us, is this valve obstructed or regurgitant valve? So what we do, giving you an example here. If you can look at the right screen here with the Doppler across the mitral valve, you have peak velocity of 2.5, significantly high. So that meets the criteria of more than 1.9, or for me, I make it easy 2. When we apply the VTI ratio, it's 2.2. So now I look at the pressure half time. In this case, it came to 98. If pressure half time less than 130, this is regurgitation. If the pressure half time more than 130, this is you're probably stenosis. So simple algorithm you use that help you differentiate between stenosis and rage. So pressure half time not used for valve area in the mitral, but we use it to help me differentiate is the stenosis or regurgitation. One slide for prosthesis patient mismatch. Basically, it's nothing wrong with this valve. Just you have a normal valve, but a small size for that person. It's like putting a mouse valve into an elephant body. So the valves were confined, but just too small for that person. The number we look for is less than 0.6 for aortic and less than 0.9. We see that with aortic valve more common, especially when the valve less than 21. So here, when we to consider TEE, if the transthoracic non-diagnostic, and I encourage you to have a low threshold for TEE in those patients. If you suspect obstruction, the next step, or there's complication that you think of. Now, don't do TE to look for the valve motion if you don't see it. Better CINI in the old days, and now we do cardiac CT better than TE. Because now, when to image, we say the fingerprint image, first echo you do after surgery. The guidelines recommend to do it 6 weeks. In my practice, I do it upon discharge when patient leaves, not the next post-op day when patient's anemic, fluid overloaded, and when they come see me back in the office in a month, we do that. This is my main. And for bioprosthetic, we do it annually after 5 years. For mechanical, usually after 10 years. And anytime you suspect abnormality, you do a transthoracic TE in those cases. So just I'm going to leave you with those take-home messages. All prosthetic valves are mildly stenotic. They're all valve, they have mechanical valve, they have mild regurgitation, that's washout jet to prevent thrombosis. And when you have high velocity and gradient, doesn't mean their prosthesis dysfunction all the time. So you need to think about patient prosthesis mismatch, hyperdynamic state, and could be both stenosis and obstruction. And always use the body surface area to assess your prosthetic valve evaluation. Thank you so much.
Thank you very much, Professor Ayman. I just have one comment for your talk. You mentioned that we don't estimate the prosthetic valve area with pressure half time. This is true, but we must measure the pressure half time to know if the valve is obstructing or not. The next thing is the DVI. The DVI always starts with the proximal lesion. When you make the DVI for the mitral valve, you make first the prosthetic the DVI divided by the LVOT. But when you measure the aortic valve, start with the LVOT divided by the aortic prosthesis. This is very important because we always start with the proximal lesion that starts from the pulmonary valves, for the pulmonary veins. So the pulmonary veins, left atrium mitral valve, left ventricle, LVOT, and aorta. Thank you very much, Dr. Ayman, and we shift now to the next speaker, Professor Ilham Al-Gaddafi. She's the Associate Professor of Internal Medicine in Tripoli University, and she is one of the board members of Libyan Society of Cardiology and the head of the working group of valvular heart disease. The floor is yours.
Okay, thank you, Dr. Azda. Good morning, everybody. Well, I am going to present the antithrombotic therapy for prosthetic valve. I have no disclosure, So, as Dr. Ayman mentioned, the first prosthetic valve implantation has been done in 1952, and after 10 years, approximately 10 years, the first biological prosthetic valve introduced in this field. And in 2002, the first transcatheter prosthetic valve introduced in the field. So we know that we have two types of prosthetic valve. We have mechanical and bioprosthesis. And we know that the mechanical prosthetic valve carries a higher risk of thrombosis and higher risk of bleeding, but it has long durability compared with bioprosthetic. So valve replacement does not provide definite cure for the patient, and the outcome of patient is affected by prosthetic valve hemodynamics, durability, and thrombogenicity. As dependent on Virchow triad, he said that the rate of thrombosis affected by endothelial injury, altered blood flow, and hypercoagulability of the body. For prosthetic valve, it has endothelial injury and it has abnormal blood flow, and this is why there is a high rate of thrombosis in the case of prosthetic valve. So the risk of thrombosis is not only affecting the valve only, but it also the systemic embolization, especially stroke. And it's higher with mechanical, with mitral valve, and with old valves. Also in the presence of other risk factors for thrombosis like AF, low ejection fraction, and hypercoagulability state. So to avoid this, we have to start what's called antithrombotic. Antithrombotic means that anticoagulation, like vitamin K antagonists, or direct thrombin inhibitors like dabigatran, or factor 10 inhibitors like apixaban, and antiplatelet. So without anticoagulation, I said before, the rate of thrombosis is higher. It's reached up to 22% for first generation of mitral valve, and with a cerebral infarction of 0.7 per 100 patients per year. 72 of these patients with a stroke will die or suffer lasting neurological impairment. But what's happened when I add anticoagulant? Okay, the risk of thrombosis will be low, but there is a higher risk of bleeding, reaching up to 1 to 7 per 100 patients per year. So I have to get a balance between bleeding and thrombosis, and I have to prescribe therapeutic dose with a therapeutic INR. So let's see this interesting study. Study هذه نداروها على تقريبا 1200 patient with prosthetic valve وتابعوهم وين بالضبط أحسن level of INR من حيث events, decrease events. يلقوا إن the best events between 2.5 and 4.9. Below 2.5, the events will be higher, reaching up to تقريبا 27 per 100 patient إذا كان INR between 1 and 1.4, and reaching up to 75 events per 100 patient per year if the INR is above 6.5. نعرفوا كويس إن الانتيكواجولانت for a life, so it affected by many things like drug, comorbidities of the patient, food, and في ليبيا المشكلة اللي نعانوا منها اللي هي lab errors, generic names, and transport and storage of the treatment. And we know that باش نقول إن البيشن يعني ياخذ في treatment كويسة وفي therapeutic range لازم تكون target therapeutic range above 60%. So what about other anticoagulants? Other anticoagulants like direct thrombin inhibitors. This is a meta-analysis done وقارنوا بينه وبين الورفرين. يلقوا إن الdabigatran carry more thrombosis and bleeding, and apixaban carry associated with high thrombosis. So the guidelines قال إن direct oral anticoagulant is contraindicated for treatment of to prevent thrombosis in a patient with a mechanical valve. وقال إن البيشن المفروض ينحطوا على lifelong oral anticoagulant with vitamin K antagonist only for a life. This is new طبعا states from the new guideline of valvular heart disease this year. لاحظوا كويس إن كل ما كان في additional thrombotic factors اللاينات مفروض تزيد. For example, mitral valve and TRICAS position إذا كان فيه additional thrombotic risk. الاي ار بتكون اعلى 3.5 بينما اذا كان ما كانش فيه بيكون just 3. What about antiplatelet? There is no role of antiplatelet for prevention of thrombosis patient with prosthetic valve. لكن قالوا إذا كان في symptomatic atherosclerotic disease in a patient with prosthetic valve, we had to add small dose with a single antiplatelet. It's not a dual, single antiplatelet. This is a class 2A. وإذا كان في patient محطوط عليه therapeutic dose of warfarin رغم ذلك صار له thrombosis، عندي حاجتين، يا اما نزيد الدوز بتاع الورفرين by just 0.5 unit والا add small dose of a single antiplatelet. This is a class 2A. باهي البيشن بتاعي محطوط على الانتي كواجلنت، هيجي كومبليننج يقول لك يا اما الاي ار عاليه يا اما ناقصه يا اما يقول لك انا عندي procedure. So we have to prevent bleeding. As I mentioned before, the rate of bleeding will be higher. This is interesting meta-analysis published in 2002. الجو إن addition of proton pump inhibitors to patient with anticoagulant, they will decrease our GIT bleeding by approximately 40%, especially in patient with high risk of bleeding, like old patient with liver, renal impairment, وpatient اللي ياخذ في non-steroidal anti-inflammatory treatment. So advised to take proton pump inhibitors. هذوما drugs اللي ينعطوا في حالة prolonged INR and bleeding. There is different طبعا vitamin K ينعطى oral and IV. fresh frozen plasma طبعا أغلبيتكم متعاملين fresh frozen plasma. اللي عندنا نقص شويه في ليبيا اللي هي بروترومبين كومبلكس كونسنتريت. الميزه بتاعتها ان رابيدلي افكتنج بسرعه، ولهذا نصح باعطائه في الميجر بليدنج. الحاجه الثانيه ان ما عندهاش الاي بي تيستنج، الاي بي او سوري تيستنج، وما عندهاش مشكله الفلويد اوفرلود اللي موجوده في الفريش فروزن بلازما. So let's go to شنو بنديروا اذا كان صارت كومبليكيشن. عندي بيشن عندها هاي ان ار with no bleeding، مقسمينها زي ما قلنا بكري، اذا كان الاي ان ار اكثر من 5 معناها هذه معرض للبليدنج. سو شنو بندير انا؟ اذا كان مريض عندي اي ان ار between 5 and 10 and he has no bleeding وما عندهاش high risk of bleeding, so I have just to stop vitamin K antagonist just for 1 or 2 doses. And there is no rule of vitamin K based on meta-analysis. إذا كان الINR above 10, yes, at that time I have to add small dose of oral vitamin K if he has a high risk of bleeding. And then after that, إذا كان vitamin K كان antagonist, I have to restart إذا كان الINR below 5. إذا كان البيشن عنده prolonged high INR and bleeding, I have to differentiate the bleeding. Is it minor or major? شو معنى major bleeding؟ معناها لا أستطيع الوصول إليه وإلا صار له life threatening condition or hemodynamic instability، معناها البيشن drop hemoglobin. At that time I have to give treatment اللي قلنا عليها بكري حسب البيشن وحسب السيتويشن. This is a meta-analysis قارن ما بين admission أو initiation of 4-factor prothrombin complex concentrate for reversible of vitamin K antagonist associated bleeding. الجو إن it's better than fresh frozen plasma, especially for patient with intracranial hemorrhage, and advised to be started because there is no increase of risk of mortality. No, this is أخطر complication of anticoagulant اللي هي intracranial bleeding. According to the European Stroke Organization guidelines published in 2019 and updated in this year in April this year، قالوا إن the best treatment وهذا طبعا اللي احنا يعني معتقدينه اللي هو 4-factor prothrombin complex. شنو هو ال 4-factor prothrombin complex؟ عبارة عن وجود activated clotting factors موجودة already، فالأكشن بتاعها يبدأ بسرعة تقريبا within 10 minutes. So in a patient it's with intracranial hemorrhage, it's advisable to give 4-factor prothrombin complex in addition to vitamin K. Vitamin K إذا كان المريض مازال عنده risk of bleeding, I have to add a vitamin K at that time. There is no rule of fresh frozen plasma. إذا كان عندك fresh frozen plasma, you have to give it with vitamin K. وطبعا اللاينار لازم نشوفها كل 30 minutes ونشوف إذا كان بعد 12 ساعة ما صارش reabsorption of bleeding I have to add another vitamin K. السؤال المهم أمتى start anticoagulant after intracranial bleeding؟ طبعا there are many studies as you can see كلهم قالوا restarting anticoagulation before 2 weeks would carry high risk of hemorrhagic complication. This is very interesting meta-analysis just published on October 21 of this year. قالوا إن delay of approximately 10 to 15 days before reassuming anticoagulant optimize the balance between hemorrhagic and thromboembolic risk, and this is advised. نفس الكلام أكد التريتمنت اللي فاتت. باهي بيشن جاني قال لي أنا عندي manipulation يعني عملية ولا dental هل لازم ندير bridging therapy وإلا لا؟ This is meta analysis قالوا إن there is no benefit of bridging therapy في patient. So البيشن إذا كان معرض لعملية لازم نحسب هل هو عنده thrombotic risk والbleeding risk والtype of surgery. This is situation in whereas thrombotic risk will be high. لاحظوا إنه موجود في الميترال وموجود أكثر حاجة في الأولد وموجود في البيشن اللي عنده 2 valves. البليدنج as I mentioned before patient عنده hepatic renal disease ولا old patient ولا patient ياخذ في non-steroidal or antiplatelet treatment. This is a high risk of bleeding this situation. This is a type of surgery divided حسب risk of bleeding according to guidelines جديدة. لاحظوا كويس ان الماينر بروسيجر نعاني منها هلبة احنا في ليبيا مثلا دنتال بروسيجر والبيس ميكر والديفربليتر ديفايس امبلانتيشن يعتبر ماينر. شو معنى الماينر؟ هذه طبعا الجايد لاينز نفصلها بالتفصيل. سبوز ان البيشن عنده ايورتيك فالف، ايورتيك فالف عاده الترومبوسيس ليفل بتاعها بيكون الترومبوسيس ذات بيكون اقل من الميترال فالف. سبوز ان ذس بيشن عنده ماينر بروسيجر اللي قلنا عليهم هذوما. الجايد لاينز يقول there is no need for bridging therapy and no need even for stopping warfarin. Okay, so continues with the procedure with warfarin. There is no need of stopping warfarin, no need for bridging therapy. باش ندير في البيشن اللي عندهم dental extra هذه أكثر حاجة نواجهوا فيها احنا يا جماعة الانتيكواجولانت. الجايد لاينز يقول ما فيش داعي توقف continues with the same treatment and you have to give topical anti-fibrotic therapy. So the guidelines say that I have to continue. There is no need for bridging therapy. الحاجة الوحيدة إني نوقفها أمتى؟ إذا كان البيشن ويبي bridging therapy، إذا كان البيشن عنده high thromboembolic risk زي البيشن اللي عنده mitral valve for example. من هم اللي اختارهم bridging therapy؟ unfractionated ولا low molecular weight؟ في هلبا ستاديز هلبا ميتا اناليسيس نشر في 2002 أكد إنه قال low molecular weight أحسن من unfractionated heparin. بهي I know. This is meta-analysis just published في February this year. قارن ما بيناتهم باثنين قالوا إن ما فيش any difference between them. So this is why the guidelines bridging therapy قال لك أنت ليك مطلق الحرية تبدأ unfractionated ولا low molecular weight حسب الحالة متاع المريض. يعني suppose المريض عنده renal impairment حنعطوا unfractionated instead of low molecular weight. أوكي. المشكلة اللو molecular weight إنه غالي ومش موجود في كل مكان. هذه طبعا الجايد لاينز ما زال ما دارلهاش حل فخلاها للجايد لاينز جديد اللي هي امتى هل نعطي الفراكشنيتد ولا لو مولكيولار ويت اذا كان المريض بندير له ميكانيكال هارت امبلانتيشن. اوكي الوقت بدا يدهمني. This is interesting case. هذه القصة بتاعتها إن she's a female عندها both mitral and aortic valve replacement ودخلت للبرايفت واحدة من البرايفت for lab cholecystectomy which is safe and simple surgery. فهم شنداروا طبعا because عندها 2 valves معناها عندها thrombosis level عالي فthey stop warfarin bridging therapy حطوها على ال unfractionated low molecular weight. ثاني يوم خشت في دروب هيموجلوبين خشت في الاي سي يو. So what was the mistake؟ المستيك هنا إن ما وقفوش الانفراكشنيتد هيبرين before 24 hours زي ما كان الجايد لاينز. This is the last slide. هذه قارنت البيولوجيكال بسرعة. إذا كان عندك بيولوجيكال سواء كان ريبير ولا بيولوجيكال فالف ولا تاذر no indication of anticoagulant نمشي للميترال. إذا كان عندك mitral valve replacement هنعطيه just 3 month vitamin K antagonist. إذا كان كلهم عندهم indication for anticoagulant I have to give anticoagulant. This is class 1A. So take-home message, INR therapeutic range should be balanced to type, anatomical position of the valve. Patient training and self-monitoring and indication can increase the INR stability. Minor or minimally invasive non-cardiac surgery procedure don't require vitamin D interruption in patient with a mechanical valve. In patient with a mechanical valve وعنده elective major non-cardiac surgery, bridging therapy may be omitted if the thromboembolic risk is low. And thank you.
Shukran, Dr. Ilham. Thank you very much for this very nice, comprehensive presentation. We will leave all comments and Q&As at the end of the session. I would like to invite Dr. Muhammad Tir now for our next talk, which is vegetation artifact in a case of prosthetic valve endocarditis. Dr. Muhammad is an interventional cardiologist at Maitiga Hospital. He's also a staff member at Asmaria University Medical School. Dr. Muhammad, the floor is yours.
Assalamu alaikum wa rahmatullah. Thanks, Dr. Hana, for your introduction, and thanks to Libyan Society for this invitation. I'm going to talk about male prosthetic valve endocarditis. So it's a quite complex topic. Please bear with me. No disclosures for this talk. My outlines will be the incidence, prognosis, recommendation for prevention of endocarditis in those patients, and then pathogenesis, diagnosis, treatment, and we'll end with take-home messages. The incidence of prosthetic valve endocarditis, it's a lot. It's a 1 to 6% of all implanted valves. And out of all cases of endocarditis, including native, the prosthetic valve endocarditis between 20 to 30%, 1/3 of all endocarditis. The morbidity and mortality of this disease is quite high. Patients who have infective prosthesis, they have twice mortality compared to the native valve endocarditis. So some studies said there may be more prosthetic valve infections compared to mechanical ones, but that's just to mention. And the in-hospital mortality up to 40%. So when we risk certify patients, who should get, the ideal medicine is to prevent, not to treat the problem. So it's important to know which patient should get prophylactic antibiotics before some procedures. And the high-risk group include previous endocarditis, surgically or transcatheter implanted valves, and congenital heart disease in patients with ventricular assisted devices. And these are just general measures, help you to prevent endocarditis in those patients, keep your teeth clean, advise your patient to do dental checkups once or twice yearly, be against habits of piercing, tattooing, maintain clean skin, treat bacteremia properly, and keep your skin clean. The recommendation of European Society of Cardiology that those patients with mechanical valves, either or prosthetic valves, must get antibiotic prophylaxis before some procedures. These are mainly dental extractions, oral surgery, or anything involving the manipulation of gingival tissue. So you can use penicillin. If your patient is allergic to penicillin, you can use other antibiotics as being seen here. Okay, it's recommended that to treat any dental issue before you implant new valves, be a period of 2 weeks at least. So it's important to do dental checkup. So the pathogenesis of endocarditis and prosthetic valves divided according to the time of occurrence, either early or late, which is less than 1 year or more than 1 year. Early endocarditis, it's the same in all types of valves. The pathogenesis is the same. If this happens within 2 months, then probably you're dealing with more staph or coagulase negative staph compared to if it happens later on where the enterococcus and streptococcal viridans are more seen. So staph endocarditis, not a benign disease. It carries a risk of a lot of complications and high mortality. So what happens here, the microorganism either invade the prosthesis within the surgery or through hematogenous spread from other sources. And that's why we encourage people to treat bacteremia in those patients with valves very, very critically. Late valve endocarditis, it's the same as native valve endocarditis in terms of causative agents or microorganisms, TAVR, endocarditis, it's 1% of all implanted valves. So staph aureus more common in case of TAVR, coagulase negative staph, enterococci, and the axis might be also important. Transfemoral axis has more risk of enterococcus endocarditis. It's about 34% versus to apical abscess. I don't think it's very common these days to do apical axis for TAVR, but I mean up to 29% would be staph aureus and transapical axis. Candidal endocarditis or fungal endocarditis in general, it's a bad disease, carries high risk of complication and mortality up to 60%. So not only left side, remember, endocarditis, we have also right side implants, not very common, but we do have prosthetic valve in tricuspid valve region or pulmonary valve replacement, especially in young adults or children. So the tricuspid valve endocarditis, it's about 11% of all tricuspid valve endocarditis. Pulmonary valve prosthesis has a risk of 34% of all pulmonary valve endocarditis. This is opposite what you see with native. The native endocarditis is more tricuspid than pulmonary. I think the RV outflow tract protects pulmonary valve in the native valve endocarditis. We have more staph on the right side and streptococci are the commonest pathogens. So mechanical versus bioprostatic. Mechanical valves, you don't see bacteria attached to the leaflets unless you have a thrombus, and thrombus can also cause complication of obstructing the valve, as Dr. Ayman mentioned. Mechanical valves, mainly annular disease. You have annular abscesses, you have fistulas, you have pseudoaneurysms. Compared to bioprostatic valves, we have vegetation, perforation of the leaflet, and those bioprostatic valves have the biofilm layer part of it, which prevents antibiotics from penetrating the valve adequately. Diagnosis is quite challenging. There is no special clinical features for prosthetic valve endocarditis. Fever, weight loss are the common with any infection. So please be vigilant of this. If you have a new murmur, probably because in case of bioprostatic leaflet perforation, or they can present with complication of endocarditis like heart failure, systemic embolizations, conduction issues. Sudden death might be because of valve dysfunction. Laboratory can help us with, you have a high CRP or procalcitonin. Blood cultures are the cornerstone of diagnosing endocarditis, and I think we're all familiar with the 5D criteria. There is major, minor criteria for definite, 2 major, or 1 major and 3 minor to confirm your endocarditis. So blood cultures, be aware you take 3 sets at least 10 ml each, 30 minutes apart before you start your antibiotics. And this is a multi-TOF culture type, gives you an answer within 24 hours if you have it available in your lab. So you gotta do meticulous sterile technique for this, taken from peripheral vein. Please do try to use aerobic and anaerobic bottles. You gotta take both cultures. And if you have used antibiotics before, you can have negative culture, obviously. The fungi and some bacteria takes time to give you positive culture. Then you might use special techniques of sequencing or gene sequencing to expedite your diagnosis. So imaging, again, some major criteria. Identify characteristic lesions of prostatic valve endocarditis. We use echo, CT, MRI, and PET scan. So we're going to go through this one by one. Echo help us establishing endocarditis, monitoring response, detecting complications, guiding our surgical intervention, and also it can give you an information about valve function and LV function as well. Transthoracic versus TE. Transthoracic means the initial modality of testing. The problem with the transthoracic, not usually accurate, especially with mechanical valves, doesn't, there's a lot of artifact as been shown previously, and cannot see small vegetations. TE remains the gold standard in this pathology. It's very good assessing mechanical valves and the complication of endocarditis around the valve, like vegetation and so on. I'm stuck here. ما تحركش Okay. Okay. So we're going to move fast. So please, this is transvagal echo showing that musculatory mass on the top of a valve. Yeah, as Dr. Ayman mentioned, but I mean, in the clinical context with endocarditis, you must make sure this is vegetation and they're proven otherwise. And this is what look like what are being taken out of the heart. So the role of echo should be repeated if you still think of endocarditis, but initial echo was negative, do it again in 5 to 7 days, or PET scan can help you in this context. If you have a new complication, is heart failure, systemic embolization, if you're shifting patients from IV to oral antibiotics. So transthoracic and transesophageal, as I told you, TE is the gold standard because of its sensitivity. It's about 82 to 96% compared to transthoracic echo, which is about 17 to 36%. Both, they have very good negative predictive value, and that's why transthoracic is the initial modality of testing in these patients. So cardiac CT, again, helps you with detecting the complications of endocarditis, root abscess, aneurysms, etc., with good sensitivity up to 97%, specificity of 95%. MRI, again, it's got low spatial resolution. That's why maybe CT scan better in terms of tissue characterization in those patients. But again, it can reclassify your patients. A lot of central system embolizations are not evident clinically. MRI can help you with those issues and can reclassify up to 25% of patients not with endocarditis to definite endocarditis because of microembolizations that you see with fever and typical clinical context. The accuracy in skeletal involvement is about 89 to 94%. This is just a CT scan showing that the aortic valve in short axis with black arrows indicating the pseudoaneurysms, and this is what you see in the 3D. The root is dilated, the left coronary on top, and the aneurysms are under. PET scan, it's got high sensitivity for inflammatory process, and this is obviously infection we're dealing with. So it shows up highly active cells taking up glucose, and this is the basics of PET scan. It tells us about intracardiac and extracardiac lesions as well, with sensitivity of 82 to 96%, specificity of 73 to 94%. It's got very good negative predictive value and positive predictive value as well. Probably false positive if done in early surgery because it just looks at the inflammatory process. It doesn't differentiate between infection and inflammation. And false negative if you use antibiotics. Okay, this is the PET scan where you see the short axis of the heart with the fluorescence, yellow fluorescence. This is what indicates there's an infection or inflammatory process there. And you see the discipline down there with embolic event as well. So if you have negative echo, PET scan can help you. How we treat endocarditis? We treat endocarditis with medical or surgical treatment, medical, antibiotic, surgical. Obviously, we do valve replacement, and there's no surgical treatment alone, medical and then surgical probably. And this is the team that you need to discuss with your patients usually. So medical treatment, antibiotics given for at least 6 weeks. You should cover coagulase negative staph, MRSAs, enterococci. But if you have a biochronological profile at your hospital, that might help you as well. So please be sure that you target your therapy with 24 hours, maximum 48 hours, allowed for you to just to target your bug. Uncomplicated, non-staph, late prostatic valve endocarditis could be treated medically. You don't have to do surgery for every patient. This has to be clear. Factors with poor prognosis, all age, diabetes, health, staphylococcal fungal infections, complications of stroke and heart failure, and multivalvular involvement. So aggressive medical treatment and surgical therapy as well. Who needs urgent surgery? Within 3 to 5 days, this is what urgent surgery means. 3 to 5, we have to eliminate bacteremia before we put a new valve. That's why it comes 3 to 5. You have to do antibiotics first, and then you put in the valve, okay? So heart failure, or endemic instability, uncontrolled infections, positive bacteremia, fungal infection, certain bacteria, and if you have a large vegetation or ongoing systemic embolization, the inventive hemorrhagic stroke, or when regard to time of surgery, if you have hemorrhagic stroke, maybe wait for 4 weeks, if you can, obviously, but I mean, the recommendation is 4 weeks, even if large ischemic stroke, because the risk of transformation, you wait a bit, but if you have small stroke, what about recurrent embolization, heart failure, maybe you're going after 10 days to 2 weeks after you discuss this with your team, obviously. So out comes medical and surgical therapy. The most important for surgery to be successful, to put the new valve in a healthy tissue. If you don't done that, then you're going to have again endocarditis. And I'm sure the surgeons agree with that. So the preoperative mortality of mitral valve is up to 13%, so it's not a good surgery you like to do. And redo surgeries may be common in bioprosthetic valves. The mortality with antibiotics is between 23 to 29%. And with mortality with antibiotic and surgery, 24 to 35. And here's the idea that comes why we use antibiotics alone sometimes in some patients. So you can't treat medically endocarditis, so you don't have to do surgery. Obviously, if you can screen your patient, as I said, for staph before you implant the valve, that would be the greatest. Please remember, hyponatremia, hypothermia, and neutropenia are bad signs. There might be a sign of controlled infection, of uncontrolled infection. Low blood pressure in this patient, not due to sepsis alone. You could have bleeding, and as mentioned, Dr. Ilham said, they've anticoagulated, so your INR goes very high after event of hypotension, like ischemic hepatitis, and then the blood pressure goes down, you don't know why, they could bleed. So please try to change your lines every 3 to 5 days, and avoid femoral lines if possible. Use mechanical support in early days. The catheters themselves, they can become source of infection, just be aware of that. If you have somebody with baseline reduced ejection fraction, you cannot use ejection fraction as a surrogate to do surgery or a marker for surgery. Metabolic acidosis, high lactate, seen with infection, obviously. But if you have abdominal pain, with this context, you're dealing with mesenteric ischemia, which is an embolic phenomenon. So it's very important to be aware of this. Hematuria, glomerulonephritis is part of endocarditis, but if you have flank pain, they have never flank pain with glomerulonephritis, but with renal embolization, you do have flank pain and hematuria. Be mindful of bone pain. The patients that have shoulder pain or leg pain, these patients, they might have embolization to the skeletal system as well and be eligible for surgery. My take-home message is prosthetic valve endocarditis carries high risk of morbidity and mortality. Please maintain high risk of suspicion. Blood cultures and timely surgical intervention could be life-saving, and there are more reasons for low blood pressure in these patients than just sepsis. And remember, antibiotic therapy failure might not be due to infection itself, but think of other reasons like catheters, lines that's not been changed. Embolic events might not be clinically evident. So thank you for your attention.
Thank you so much, Dr. Muhammad Attir. We will postpone the discussion for the end of our session. So I call Dr. Omar Mankush for the next talk about redo valvular heart surgery. What are the challenges and the risks? And of course, Dr. Omar Mankush is a consultant cardiac surgeon in Phoenicia Hospital in Benghazi. The floor is yours.
Thank you. Assalamu alaikum. I'll talk about redo valvular surgery. I have nothing to disclose. My talk will cover the indication, patient-related risk factors, technical challenges in these operations, operative and post-operative risk factors, minimizing risks and using alternative strategies, and I will end up with the take-home message. Redo valve surgery, most of the time indicated for failed bioprosthesis. As we'll see in the next few years, we'll have more of these cases, young patient with implanted bioprosthesis, with TAVI coming into the field, prosthetic valve infection, another reason for redo, significant paravalvular leak, where percutaneous closure is not possible, valvular thrombosis and venous formation over the valve, and severe prosthesis-patient mismatch. These patients are higher risk than the first case surgery because they are usually older patient, they carry more comorbidities, they have previous bypass, especially if they have a patent graft, which is crossing the midline, will put them at high risk of injuring these grafts. Functional status of the patient, especially if they are New York Heart Association class 4, will increase the risk. Like any other patients, kidney, liver, and lung diseases put them at high risk, and usually these patients, some of them come late to surgery because of either refusal of operating on them or managed by cardiologists, avoiding to send them to the surgeon. And emergency cases like infective endocarditis, as we said before. And these cases usually come very sick, sometimes with end organ failure. What's the technical challenges meet the surgeon in this case? I will go through what we should do during surgery. In these cases, we mark the femoral vessels and sometimes the axillary vessels on the skin before surgery, so we can have quick access if we need, or if we plan ahead to cannulate this patient through femoral line. Applying external defibrillation paddles for this patient, as sometimes the heart fibrillates during this section, and you cannot use internal defibrillation paddles, and so you have to defibrillate them through these pads. Sternal re-entry, this is one of the major steps. You can injure the ascending aorta, especially if it's calcified and close to the sternum, and this has caused catastrophic bleeding, or innominate vein or right ventricle if they are close to the sternum. Therefore, you should usually in normal surgery, first case surgery, we deflate the lungs. In these cases, usually you ask the anesthetist to keep the lung inflated, to try to separate the mediastinum from the sternum. We use oscillating saw rather than the jigsaw. If we can cut the anterior tablet of the sternum followed by the posterior tablet. Once we divide the sternum, you cannot apply a sternal retractor in these cases, otherwise you will right atrium. So we have to tackle each hemisternum separately, taking caution with the traction with your assistant. We usually start from the lower part of the sternum using diathermy and blunt dissection, and we progress upward, tackling each hemisternum at a time. Once the sternum is freed, we can apply our sternal retractor. And we don't, a lot of time we go through the pleura bilaterally, so that's okay. Once we free the sternum, this is a big hurdle of redo surgery. The next hurdle is tackling the heart and freeing the heart from the pericardium and having access to bypass cannulation. Usually the cannulation site is the difficult site where you have dense adhesion over the ascending aorta and right atrial cannulation site. So the trick is to take your time. The area you dissect, make sure you pack it before you move to the next area to minimize the bleeding. And sometimes we leave piece of pericardium on the cannulation site of the right atrium. Otherwise, you end up opening the right atrium. Either to carry on and dissecting the heart completely if everything is favorable and things are not too bad in terms of adhesions. Otherwise, we may have to cannulate first and giving heparin, putting the patient on bypass, and then free the lateral wall and posterior wall of the heart. Cannulation strategies, as we said, either you go central. If you think preoperatively things are in favor. Otherwise, if we think the risk is high and the sternum attached to the mediastinum, so maybe it's safer to cannulate the femoral vessels, go on bypass, and then make your sternotomy. Obviously, it will be more bleeding because of the heparin. So you have to make balance between these two things. Once we are freed the heart and we cannulated, you may have to consider using retrograde cannulation for myocardial protection and cardioplegia, especially if you have significantly diseased native or grafts. Operative and post-operative risks. Overall mortality and morbidity for this patient reported 2 to 4 times as bad as a first-time surgery, obviously because of these technical issues. Prolonged ventilation and hospital stay for this patient compared to first-time surgery, increased bleeding and blood transfusion because of the reasons we mentioned. Acute kidney injury, stroke, arrhythmia, wound infection, all these post-operative complication is higher in the redo cases. How to minimize risks and using alternative strategies to improve the outcome. As usual, heart team approach is very important in all cases, especially in these cases where you might consider sending this patient to another center, helping from your interventional cardiologist. Our radiologist might help in that. All these patients, they should have CT to delineate the relation of the sternum to the heart, calcification in the aorta, and this will help you to plan your technique. TUE is a must in this case to know the pathology of the heart, of the valve. It's degenerative, there is vegetation on the heart, paravalvular leak. If you know this information ahead, it will make your life easy intraoperatively. Preoperative optimization and risk mitigation for this patient, like any other surgery, cessation of smoking, rehabilitation of the lung, controlling diabetes, optimizing the lung function. All these will improve your outcome. In these cases, if we have bleeding intraoperatively, we use fibrinolytics and anticoagulation factors liberally. So in minimally invasive surgery, if you think, and this comes the heart team approach, if you think the risk is high and the heart is adherent to the sternum, calcification of the aorta, you have patent graft crossing the midline, so maybe using alternative routes through right thoracotomy, especially in tricuspid and mitral valve surgery will be a better option, or anterior thoracotomy for aortic valve, and this will avoid opening the stent. If you have the luxury to send the patient to TAVI operator, where you can have valve and valve and avoiding resurgery, this is a good option, although these cases are reported very small number, even in high volume, but I think it's doable, and in the future we'll see more of these cases. If you have one of your colleagues who do more redo surgery, try to refer your patient to them. If you have a better center, either locally or abroad, maybe that's better for your patient rather than to open the case yourself. Take-home message. Discuss this case in a multidisciplinary meeting. It's good for you and for your patient to do that. If you have a chance to send this patient to a better place, do that, please. as literature showed, high volume cases with long experience in redo cases, they improved the outcome to almost equal to the first case surgery. But these centers who are doing like 500, 700 case redo a year, they achieve that. So it's doable in these centers. So try to get your patient the best chance by referring them to these centers. Thank you.
Thank you, Dr. Omar. We are ready to take any questions from the audience.
Bismillah. Thank you for all the speakers for the nice presentations. First of all, I would like to ask Dr. Gaddafi about the present state-of-art management, anticoagulant management for pregnant ladies. Number two, regarding endocarditis, I think the message is not to wait too long. We used to wait, give patient antibiotic, and wait for 6 weeks. I think in most of the cases, that's a recipe for disaster. So if you have a high-risk patient, special staph aureus, go early for operative management. The last comment is for redo surgery. Certainly, it's a nightmare for the surgeon. However, things has changed a lot in the last few years, and improving the tools and anesthesia, as well as we find using bipolar diathermy for mobilizing the heart midlife much easier and much safer than the old way of dissecting. Thank you.
Thank you, Dr. Mohammed. Dr. Ilham, if you can answer the first question, please.
Okay. شكرا دكتور محمد استاذي. طبعا انا ما جبت السيره للبريجنسي لان البريجنسي بروحه كيف طالع جايد لاينز جديده، لكن كصوره بسرعه هيك ان we know that warfarin is contraindicated in the first trimester اذا كان اكثر من 5 ملغ، لان طبعا it's cross placenta and cause teratogenic effect. So it can be safe to be used throughout the pregnancy إذا كان الدوز أقل من 5 ملغ. But we have to stop it before normal delivery, 2 weeks before normal delivery, to protect the fetus, because it's زي ما قلت cross the placenta, so it can cause intracranial bleeding بالنسبة للبيبي. So this is for warfarin. For الهيبرين it can be used both الانفراكشنيتد واللو molecular weight. مشكلة اللو molecular weight في ليبيا ما عندناش how to measure anti-factor 10. ما عندناش في اللاب، لا في برايفت ولا في حكومي، فلهذا لا نستعمل فيه، لأن في البريجنسي الريت متاع الترومبوسيس بتزيد في البريجنسي. So you have to follow up your patient. إذا كان حطيت على low molecular weight لازم تكون اللو molecular weight متاعك تتأكد منها أنها تخدم كويس ولا لا، باتباع الأنتي فاكتور 10 اللي ما عندناش، ولهذا ما نستخدموش فيه، نستخدمه في الأرفراكشنيتد هيبرين. للأسف أنا أعطيت محاضرة طبعا عم نول كان في المؤتمر القلب في مصراتة تكلمت عليها. النقطة متاع الأنفراكشنيتد هيبرين اللي نعطوا فيها البريجنسي نعطوا مخالف للجايد لاينز. أغلبية المرضى ينحطوا عليه سبكيتينيوس، وهذا مخالف للجايد لاينز. الجايد لاينز يقول إنه we have to start with IV infusion، يعني البيشن حترقد في المستشفى وحتنحط عليه IV. مشكلة متاع الانفراكشنيتد هيبرين حيكونوا معرضين لترومبوسيتوبينيا ومعرضين للأوستيوبروسيس، وطبعا في ادميشن معناها يعني سوشيالي مش محبذ للبريجننت بيشنت. فمختصر مفيد للبريجننت بيشنت في ليبيا يعانوا كثيرا اصحاب طبعا او صاحبات البروستاتيك فالف. وطبعا لازم يوقف الهيبرين قبل الولاده ب 24 من 12 ل 24 ساعه and we have to restart الانتيكواجولانت بعد الدليفري. طبعا لازم يكون في حاجه اسمها هارت تيم اوكي في البريجنسي بالذات، وهذا طبعا مفقود في ليبيا. فمختصر مفيد المانجمنت اوف بريجننت بيشنت وذ بروستاتيك فالف تعتبر تحدي كبير جدا بالنسبه لنا في ليبيا. شكرا.
ثانك يو دكتوره الهام. دكتوره عزه.
يعني بشكر طبعا كل السبيكرز but I want to share with you a case. We just see it in our staff round last week before I came here, and this case is really problematic, but it's related to the old topics you present in your lectures today. She's a 27-year-old female patient with rheumatic heart disease, and she underwent mitral valve replacement very smoothly for severe mitral regurgitation and moderate mitral stenosis. But after 8 months, she developed a thrombus stuck valve and thrombosed occluder at the site of occluder. Actually, she was very compliant on the vitamin K antagonist, and her INR was 3 to 3.5, and there was nothing to explain why she developed thrombus. She underwent redo surgery, and for a while she was very compliant on her anticoagulant therapy, and after another 6 months she got another stuck valve. Both valves were St. Jude valve, and you know that St. Jude valve is a bileaflet valve with excellent hemodynamics, excellent durability, and very low thrombogenicity, and the patient has nothing to do with any other anti-hypercoagulable state. She's not having protein C or protein S or antithrombin 3 deficiency. Factor V Leiden is not done, but we are considering a lot of issues. Make her redo surgery for the 3rd time, and we don't know why she has this bad luck of thrombosed occluder for 2 times with 8 months apart and then 6 months apart. The other thing is something we read about this problem, and this was published in one of the prestigious journals. I don't remember. I think it is in the American Journal of Cardiology, and it is from Indian team. They try to improve this stuck valve with balloon dilatation inserted between the 2 leaflets. Sometimes in the narrow opening of the bileaflet valve, and sometimes if the occluder thrombus is present near one of the wide openings, so they introduce the balloon to relieve this obstruction. They actually did 27 cases, and they published these 27 cases with a success rate of about 90%, but actually the 10% have major stroke. Some of them have acute pulmonary edema due to strut fracture and, of course, death on table. So, do you have any ideas about why this patient developed this? I think the guidelines tell that the condition will be another surgery for the 3rd time. Despite the fact she's properly anticoagulated, she has nothing to do with any hypercoagulable states.
Thank you for, yeah, that's a very interesting case. I remember seeing one case similar to this during my practice in Canada, and we did everything. We found lately, actually, the patient was non-compliant, although she was saying that she's compliant. And after that, she actually went to psychiatry because she has psychiatric issues. So compliance with patients is extremely important. Sometimes we miss that, or we assume that the patient's taking the medications, the right dose, the timing, compliance with diet, especially warfarin, need to make sure there is no other medication that interfere with the drug, or food that interfere with the drug. So that's just my 2 cents for such a case.
But her INR is 3 and more. She's properly anticoagulated.
Yeah, Sana has one. I mean, is there an idea that we can try factor 10 inhibitors instead of?
Sorry, try what?
By the guideline, obviously. And I understand. Like this, she has no chance. Third time, yeah. And I'm saying why. What I'm saying is, if she fails warfarin, and she's been checking her INR, which is her INR, which is therapeutic. So there's no question that she's not taking the warfarin. She's taking the warfarin, and despite that, she's still thrombosing her valve. So is it in the valve, or is it in the drug?
It is in the occluder.
Occluder itself.
Yes.
So yeah, I'm saying the occluder, is it, when you do the echo, is it like showing obstructive or?
No, we don't see by repeated TE, including 4D TE, we don't see a thrombus. This time, we don't see a thrombus. But the valve strut is stuck
it's not moving.
In opening position, and it's always like this by fluoroscopy.
Yeah, I get the warfarin, okay.
Okay.
Can I just add, it's the treatment. Did you try thrombolysis for this patient? And why
Yes,
she
we tried heparin and we tried thrombolysis, and there's nothing to improve. Yes.
Thank you, Dr. Azza, for sharing this interesting case. I'm not going to talk about like what caused the thrombosis, because it's there, it's a fact. I think when you don't see it with the TE, this is a good role for cardiac CT, because have advantage over it. This is something that we see where it practice at the Cleveland Clinic. We have a large population, young with rheumatic heart disease, and they come with valve thrombosis, like what Dr. Abdul-Ghani says, complacent issue. I know not in this case. We have a heart team approach with them, what Dr. Omar emphasized on. We talk about like the risk of thrombosis. So we offer them bioprosthetic valve. This patient failed the first mechanical valve due to thrombosis, whether she's compliant, whether there's like undiagnosed hyperthrombus late. The next sternotomy, increased the mortality of the patient significantly high. Now we have this conversation with the patient that we can do a tissue valve. It's not going to last as long as the mechanical valve, but there's thrombosis is lower. And especially now with the advantage of like valve in valve, these are new opportunities. So these are things in similar to this case, even though the guidelines would say mechanical younger than 50, if you apply the guidelines 100% of the time, you're not doing a good job. The guidelines in general for disease structure, but every patient is different. So those are things, at least in our practice Cleveland Clinic, when you have patients with mechanical valve thrombosis, the next step will be heart team discussion, shared decision making with the patient, because we don't want another thrombosis and second and third surgery. Thank you.
You are right, Dr. Ayman. And we take a decision of making tissue valve for this lady. I think it will be next week for something. Thank you.
I just have a comment about infective endocarditis. This is a message to our cardiologist colleagues. We have very few patients referred for infective endocarditis, and usually it's wrong referral. As soon as the cardiologist see vegetation, they send it to the surgeon, and these are the least patient benefit from surgery. Actually, the one who benefit from surgery who have hemodynamic problem. Even if the patient is very sick, went on their dialysis, if you refer this patient, they have surgery, and if they are young, they do very well. The other category of patient is no response to medical treatment. Do not wait for a long time till they develop abscess formation and destruction of the valve. 1 week, no response, surgery is indicated. Thank you.
Thank you very much. I want to share with you something about the infective endocarditis in the prosthetic valve, because we are a tertiary center in Egypt in Cairo University Hospital for referral of cases of infective endocarditis. What do you, how to make a decision for a patient with infective endocarditis on a prosthetic valve regarding anticoagulation? You know that there is a very high chance of developing mycotic aneurysms in the brain, and we see a lot of cases of mycotic aneurysm, not just in the brain, in the peripheral circulation, in the lower limbs, and in the mesenteric vessels. So we do something, a protocol, that after 2 weeks from the patient being in our hospital, receiving his antibiotics, we make 4 vessel angiography as a routine after 2 weeks. And if we find any mycotic aneurysm, we make a coil implantation for these microaneurysms, and some patients develop another mycotic aneurysm in the peripheral circulation. We also coil this to continue the anticoagulation safely. I don't know if you adopt the same policy or not.
Yeah, good point, Dr. Azza. It's if it's in a high risk, as you said, centrally or causing ischemia, then probably put a coil there. But a lot of them, they improve even with medical therapy, with antibiotics. Those aneurysms, I mean, fortunately, they improve with time. So yes, if they're in high risk position, definitely you have to coil them, there's no question. I don't know, the guidelines don't say specifically if you have to do a CT angiogram to OR2A3, but you must do PET scan, and also it can show you the CT scan if you do it properly. The multi-slice 128 probably can show you those arterial systems, and if there's any large mycotic aneurysm, they even bleed those aneurysms, not just they cause thrombus, they also can rupture and bleed. So, but I don't know, good if you do it within 2 weeks, meaning that the bacteria has to be eliminated, and they should be responding to therapy if they have no fever and so on. So, and you don't expect aneurysms to be there. I think that's what you're saying.
I think we adopt this policy and publish it in the PLOS One journal, one of the prestigious journals for the German Society of Cardiology. But we do this because we see a lot of patients with cerebral hemorrhage following anticoagulation, the proper anticoagulation with infective endocarditis and a prosthetic valve.
Just before we conclude our session today, first I want to thank all our speakers for their very nice, informative presentations. I just want to conclude with a few remarks, let's say. The first one is we still lack a lot of adoption of guidelines in Libya. And probably one of the major problems we have is that we get patients on anticoagulant prosthetic valves referred to us all the time just because they want to do dental extraction. They want us to stop their anticoagulant and they reduce their INR. And no matter, we try to explain to the patients and we send our message to the dentists, but this is really something for minor procedures that don't need stopping their anticoagulant. Those patients get their anticoagulant stopped, so we really need to get the message across as much as possible that those patients are at a very high risk of thrombosis and we shouldn't do that. Another problem or issue that we have in our practice is that unfortunately 2 things. One of them is that most of the time we don't get any growth out of our blood cultures. We don't have the more advanced, sophisticated investigations that show us what microorganisms are grown from the blood cultures for their prosthesis. And I just want to, one last thing I want to say here, that in the last few months we did this study and we took swabs from the mouth flora of patients with prosthetic valves. And the microorganisms that were taken out from the mouths, like the microbiologists, they were amazed. Even the Staph aureus are very resistant. They did the microorganisms and they did the antibiotic sensitivity, and they found that they're all MRSAs, and there's another antibiotic now, the name is gone, it's resistant to that as well. And this calls for, we need to have our local guidelines for treating patients with infective endocarditis, because our microorganisms don't respond to the regime that's being put. And we do, I think Dr. Omar knows, we've had quite a few patients with quite severe infective endocarditis and very bad complications. So thank you again. I would like to remind you that we have a coffee break now, but please come back. There's another very nice session. Dr. Azza will be presenting as well this afternoon, but at 11 we have a session. And we also have the LCS Jeopardy today. We want you all to attend it. And we'll see you later. Thank you.